Good afternoon. My name is Dr. Clement Muka. Today I'm going to talk to you about a protozoan that causes malaria. Malaria is a disease that can be controlled, but if it's uncontrolled, in other words, it's not treated, it can be fatal. Malaria is caused by a protozoan known as Plasmodium vivax. Vivax is a species, Plasmodium is a genus. So the vivax belongs to the genus Plasmodium. That's not all. We have Plasmodium ophale, we have Plasmodium malaria, we have the last one, that is Plasmodium falciparum. These three, the first three, Plasmodium vivax, Plasmodium ophale, Plasmodium malaria, they cause malaria, but a very mild malaria. It can be chronic, it can stay there for years. But Plasmodium falciparum, that is the one that is severe. That is the one that has fatalities. It has got to be treated forthwith, immediately. That's Plasmodium falciparum. So how does this happen? Plasmodium falciparum, Plasmodium vivax, Plasmodium ophale, Plasmodium malaria, all of them, they are transmitted by a vector. And the vector is your mosquito. So you need to be bitten by a mosquito, and a mosquito that is actually infected with shall I say, an infected mosquito. And then being bitten by this, it will cause a wound. And in that wound, a motile spore known as a sporozoid will be deposited. And this motile spore, like I say, it is motile. It will move and get into the bloodstream. And bloodstream takes it straight to the liver. It takes it to the parenchyma of the liver. And there, in the parenchyma of the liver, it starts multiplying. It starts multiplying in the parenchyma of the liver. And then forming a cyst. And in this cyst, you'll find the cyst full of daughter cells of the sporozoid. The daughter cells of the sporozoid are given a special name. They are known as merozoids. So we move from sporozoids to merozoids. And merozoids are just the daughter cells of this. And these merozoids, the merozoids, I'm talking about thousands of them. When they are liberated from this cyst, they start looking for an erythrocyte or a red blood cell. And the erythrocyte, because they feed on the hemoglobin in the erythrocyte, they feed on that. So it is not surprising, therefore, when you find what is known as hemolytic anemia, because the sporocyte, the merozoid, is going to break down this erythrocyte to try and get the hemoglobin. It feeds on the hemoglobin. And then, feeding on the hemoglobin, it's not surprising, therefore, to get hemolytic anemia. The hemoglobin goes low, goes low, goes low, and that causes the anemia. Good. And so this is what happens. So there's a stage of proliferation in the erythrocyte because it's feeding on this erythrocyte. And it gets out of an erythrocyte, and these merozoids, they look for other erythrocytes. So the end of the cycle of malaria is a merozoite. In other words, you get this merozoite being deposited onto blood and looking for other erythrocytes, other red blood cells, where it will multiply again into merozoites. Merozoites, that's what makes a patient, shall I say, a source of merozoites. It's a source of merozoites to any mosquito that is walking around or that is flying around. Any mosquito, when it feeds on this particular patient who's having this. And the most important thing to understand is this can happen to Plasmodium vivax, this can happen to Plasmodium opale, this can happen to Plasmodium malaria. So it can happen even to the severest one, the Plasmodium falciparum. Now, what exactly, if we're looking at the mosquitoes, it is only the Anopheles mosquito, and it is a female Anopheles mosquito that carries this parasite, this merozoite. It is carried by this, and if it is from the Plasmodium falciparum or falciparum, if it is from the Plasmodium falciparum, then we are worried, because that is the one that is most severe. The others are not. They can be chronically there for years. But this one, it goes only, if it goes for months, it goes just days, a week, and after a week, at the most a month. If it is not intercepted, there's nothing done to try and deter its progression, then there are gonna be problems. It is treated so very much easily. You know, I've seen in public hospitals, they do very well with the treatment of malaria. If a patient comes with malaria, there's chloroquine that is being used. But chloroquine, you can have chloroquine, you can work with chloroquine, But sometimes you get a strain of falciparum, in other words, Plasmodium falciparum, that is being resisted, that is resistant. It's resistant to chloroquine. And then in that case, you have to go over to, well, you can have something called primaquine. But primaquine is not that much popular in this country. And the one that is popular is quinine. But quinine has got to be used with parathyramine. It's got to be used with that. And also with sulfonamide. A sulfonamide that you can use. So you use quinine, you use parathyramine, and you use a sulfonamide. Sulfonamide that we use so much is sulfodiazine. So if you use these three, quinine, a sulfonamide, and make sure that you combine with parathyramine, and then you combine them, these three, you find that they are effective. But when we're using quinine, one has to be very careful. You have got to get worried about, is there any cardiovascular problem here? If there's a cardiovascular problem, you take some few steps back, or you are, well, these patients are normally treated in a hospital setup. Get someone senior to oversee this patient, because with quinine has got some cardiovascular problems. You know, I think this brings me to a very important point. How does Plasmodium falciparum, how does it kill patients? Or how does it, how is it a problem to patients? It causes what is known as capillary constriction or capillary obstruction. It obstructs the capillaries. Capillaries in particular, you have to divide them. Capillaries which go to the cerebrum. This cerebrum, it causes, in the cerebrum, it causes problems like hemiplegia. It causes convulsions. It causes, problems like that, CNS problems, convulsions. It causes dementia. It causes delirium, and it causes a coma, and a coma leads to death. So CNS problems or CNS infection with these merozoids, when they infect the brain and they multiply there, they cause this capillary obstruction. And capillary obstruction is manifested by hemiplegia, is manifested by convulsions. This is in the CNS. Is manifested by delirium, is manifested by a coma which leads to death. That's how patients die. So if you've got cerebral malaria, in other words, you've got these merocytes teeming in the brain, like that, then what you can expect is a hemiplegia. You can expect convulsions, you can expect delirium, you can expect a coma which leads to death. But if it is the pulmonary area where the patient experiences these obstructions, pulmonary obstructions, they cause coughing and they cause hemoptysis. In other words, a sputum that is streaked with blood. You notice that. That's what you notice with the pulmonary area. What do you notice with the splanchnic area? That is the abdomen, splanchnic area. The patient is going to have severe vomiting. The patient is going to be nauseous and vomiting. And then the patient is going to have millennia stools. You know, this is what happens in the splanchnic area. Also, what happens in the renal area? What happens in the kidney? The patient is going to have oliguria. In other words, the urine is going to be minimal. Sometimes when it goes on, they go to an extent of having anuria, no urine at all. And these patients, they normally get into, once they are like that, they normally get into renal failure. And renal failure, as we know, it precipitates a hyperkalemia. And the hyperkalemia causes cardiac arrest. Patients die because of that. So basically, that is what is happening with malaria, and that is why intervention is so very much important. And so when you go with say you want to use quinine as an intervention method, you want to use quinine, make sure that subsequent to that, or in addition to that, you use a tetracycline. The tetracycline of choice that we normally use is doxycycline. So if you use, it's just that one has to be careful using quinine. Quinine will always have these problems of cardiovascular problems, like a tachycardia, hypotension, orthostatic hypotension actually. Orthostatic hypotension, when the patient stands up, normally the blood pressure crashes, goes right down. And you know, if that happens, a blood pressure that goes right down, it threatens the brain. The brain can't afford not to have blood, because blood has got to be supplied to the respiratory center, which controls respiration. Has got to be supplied to the cardiac center, which controls the beating of the heart. So this is a big problem if you are using quinine. When you're using quinine, you've got to have somebody who's very much knowledgeable about control of the heart, because if there are cardiovascular problems, it's always a good idea to go to the others like chloroquine, like the others, and parathiamine, and use the others, or have somebody to supervise who is senior. The medical department now is normally very good in this area, management of malaria. But I wanted just to make sure that I discuss malaria. I've seen it, killing people. I don't know whether maybe it's late intervention or what, but I've seen it killing people. I mean, and people who were supposed to be knowledgeable. I mean, at one stage it killed, you know, people who are in clinics. And malaria is never treated in the primary health care sector, that is in South Africa, in our clinics. No. We always refer those patients to hospital. So that's the most important thing that one has to understand, has to know, how do I intervene? How do I intervene when a patient has got malaria? We've got a malaria test to diagnose it. We've got a malaria test just specifically for malaria. For malaria test, and then you use that, and it will demonstrate if the malaria is there. And of course, treatment is very much crucial when it comes to this one, because if the patient is untreated, then you can, and the patient maybe, shall I say, Plasmodium falciparum has been isolated, and we know that it is the most severe one. It is the most severe one. Then we know that patient will die if the patient is untreated. So it is important to understand that Plasmodium falciparum, we are going to take all the steps to try and make sure that this patient is treated. This is one protozoan I would have loved to discuss. One protozoan, you know, protozoans, they are unicellular, but they can be very, you know, if untreated, they can, you know, kill patients, and we don't want that. Thank you very much. I am happy and excited that you have listened to me, and I hope you will think about this and think about how malaria is transmitted. You get it in swampy areas. You know, the word malaria, just to say malaria, it means bad air, because people used to get it from swampy areas. This bad air, they used to get it. And I think that's not wrong, actually. That's actually right, because this Anopheles mosquito, this female Anopheles, you get it in swampy areas. So people used to just say, hey, there's malaria here from the bad air. Bad air means malaria. Right. So this is what people, you know, if you come from a malaria endemic country, it's important to disclose that to your doctor and say, I visited a malaria endemic country. That saves patients, you know that, because treatment of malaria, I mean, death from malaria is actually unnecessary with the treatment that we have. We have something to counter this, right? Thank you very much. Thank you very much. Thank you very much.